This film takes the form of a semi-structured discussion between myself, Dr. Sarah Human, a consultant in palliative medicine, and Dr. Mick Mercer, a consultant in intensive care medicine. I'm seeking some more information and some clarification about the new TEP form, and Mick has kindly agreed to meet with me to go through some questions that I've prepared. Mick, thank you. Thanks for meeting. I'm sure this is going to be helpful just to run through a few of the questions and issues that have come up about the new TEP form.
Okay.
Firstly, an easy question. What does the abbreviation TEP stand for?
Yeah, it's a treatment escalation plan, the new TEP form and TEP process.
Treatment escalation plan.
Yes.
And how and why has the new form been developed?
We started in the acute sector a few years ago now with the TEP form as, if you like, moving on from the DNAR, do not attempt resuscitation forms that we had in our trust, to broaden out the plan of care for our patients, so it didn't just focus on cardiopulmonary resuscitation, but we started to wrap it up into a more wide patient plan, the TEP form. We've now moved on beyond the acute trust and are rolling it out across all of Devon, in the acute sector, into community trusts, into patients' home. So we're covering every patient in the whole county.
Okay, so a Devon-wide form.
Absolutely.
Across all healthcare
Absolutely,
settings.
yes.
And just a little bit more detail, you alluded to it, in how the TEP form differs from the whole host of different do not attempt resuscitation forms that have been out there previously.
Yes. DNAR concentrated on cardiopulmonary resuscitation. Do we attempt cardiopulmonary resuscitation or don't we? Which is a good question, clearly. But we think we can go beyond that narrow remit into a more broader, holistic patient plan, where we seek answers to questions such as: would antibiotics be an appropriate thing? Would intravenous fluid be an appropriate thing? Yes or no? And then moving up the scale, if you like, to: would admission to intensive care be appropriate? And even on the intensive care, would ventilation be appropriate? Would inotropes be appropriate? And then also including in that the DNR question: would cardiopulmonary resuscitation be appropriate? Yes or no? So we've looked at a more holistic plan, but one of the extra key ingredients in the plan, which particularly relates to the community, is: would admission to the acute sector, the acute trust, be an appropriate thing? Yes or no? Patients in a nursing home, if they were to become ill, would it be appropriate to admit them to the acute sector? And that's one of the questions that we'd like to get an answer to on the community, county-wide TEP form.
So an approach that, sort of wherever the patient is, allows us a little bit of planning ahead, thinking ahead about potential treatments and how we might plan someone's
Absolutely.
care.
Absolutely.
And which group of patients do you think we should be thinking about who may benefit from using a TEP form?
Yeah, we've started here locally with those patients that we think are at risk of suffering a clinical deterioration and going on to the point where it may become life-threatening. And obviously all part of that group is also those patients that are near the end of life themselves. That, I have to say, is our local and my trust's interpretation of who would be a candidate for a TEP form. Other trusts interpret it slightly different, and some trusts look at every patient that comes through their front door, because you can fill out a TEP patient for every patient. It may be the answer to all the questions on the TEP form is it's a yes to every form of resuscitation, which is still clearly very appropriate for an individual patient. So it's a matter of individual interpretation, if you like, for the health trust, which patients they'd like to see undergo the TEP form and TEP process.
So it's a Devon-wide form, but local ownership and interpretation is in there as well. And whose responsibility is it to fill out and complete and sign the form?
Yeah, the key thing is a clinician who knows the patient and their circumstances well, and hopefully also knows the family well. Someone who knows what has discussed with the patient and the family, and is in a position where they will know their wishes, given that the patient may then go on to deteriorate. So the key is someone who knows the patient and their wishes, and has discussed it with them and knows their wishes well.
So that could be a hospital consultant, GP, hospice consultant.
Absolutely, yes. But ideally not someone who's just been parachuted in and is meeting the patient and the family for the first time, and is then all of a sudden asked to be making these having a very important discussion and making very important decisions.
And I think that's an important point, isn't it? That this may be something that is a process that takes a period of time rather than necessarily having to be done immediately.
Oh, absolutely.
If I can summarise so far, this is the TEP form is a clinical decision-making tool, so that doctors can make individual treatment plans for their patients. It doesn't just sort of document resuscitation status, but it looks at a sort of range of treatment options, including for those patients out in a community setting, the option of whether it's appropriate to come into the acute hospital.
Yes.
It's a means of communicating and sharing information with other healthcare professionals, whatever healthcare setting the patient's in. And I guess it complements advanced care planning that's going on out there already.
Absolutely.
You envisage the form being most helpful for that group of patients in whom we we anticipate a deterioration in their condition.
Yes.
Maybe a patient who's at risk of cardiac arrest or respiratory arrest, and patients in whom we can see that they're approaching end of life.
Yes.
Mick, I think these are potentially really difficult, challenging things for us, decisions for us as doctors and patients to think about and to talk about. How much do you think we should involve patients and their families in discussing treatments and helping us to fill out the TEP forms?
Excellent question. I think it's vital that we include the patient, assuming they have a mental capacity, and failing that, the family in these discussions. After all, this is one of the thoughts behind this whole process, is we want to ascertain the patient's wishes, given that we think that they may go on to suffer a clinical deterioration. So we want to know what the patient wants if and when that deterioration does arrive, so we can put their wishes into action, and we're not left guessing what the patient would want. Obvious scenarios: the patient becomes sick and they lose capacity, and then we're left not knowing what they would really want us to be doing in those circumstances. So yes, we need to be talking to the patient and family early on to ascertain their wishes, having a conversation, and the results of that conversation are then documented in the TEP form.
Thank you. Just got a couple more practical questions about the form. Is it necessary when you're completing the form to tick every box and answer every question?
No, do what you can. Yeah, there will be questions that you, as a clinician, may find difficult to have the knowledge base to enable you to answer those questions.
Yes, you might not feel comfortable or have the experience to know how to answer them.
To do what you can. You don't have to feel the onus to fill all the boxes manually.
And are we allowed to photocopy the form, or is it just the original form, the acceptable, valid form? Yeah,
the hope is that the original form, only the original form, stays with the patient throughout their patient journey, wherever they may be in the health sector. And that's the form that we hope to act upon. Yes, it may be you want to photocopy it, say for your acute hospital notes when the patient's leaving, to have a copy in your notes, but the real live, valid document is the one that's in the patient's hand.
And that stays with the patient?
Yes.
And for patients at home, do you have any suggestions about what advice we should give them on where to keep that?
Yeah, that's a tricky one. That's obviously very individualistic. Sometimes we say perhaps stick it on your fridge with a fridge magnet so everybody knows where it is. But obviously that depends on individual circumstances. If you're in a care home, maybe the TEP forms on patients in the care home are filed in the manager's office. The key is the TEP form needs to be wherever it may be. We need to know where it is. The staff or the patient in their home or their family need to know where it is, such that it can be accessed quickly and easily if and when a medical emergency arises.
So quick and easy access, people know where it is.
Yeah.
One of the things we've been advising our patients who have community notes at home in yellow folders is to stick the form right in the front of their yellow folder. Now, advanced decision to refuse treatment forms are legally binding. Is the same true of the TEP form?
No. This is a signpost care. We don't expect an attending physician and attending paramedic to be bound by the contents of the TEP form. This is a signpost guidance on what care the patient wants to be delivered at the time. And yes, that's how we'd like it to be seen, not something you're rigidly held account.
So a guidance as to what's thought to be the best plan, but obviously the circumstances at the time may dictate otherwise.
Yeah, may dictate variance from the plan.
Okay, so using your sort of clinical judgment at the time.
Yes.
And if the patient already has an advanced decision to refuse treatment form specifying within that they don't want to have CPR, do we need to do a TEP form that includes a decision about CPR as well?
I would say yes, because obviously the ADRT that has only stipulated what happens in the event of cardiopulmonary resuscitation. Yes. That's one of the philosophies behind doing the TEP form itself, is to broaden out that care plan so we know what we do in a more holistic approach in terms of admission to the acute trust, yes or no, or admission to the intensive care, yes or no. So I would say yes. Don't just fill out the CPR question, if you like, which you see on an ADRT form. The TEP form will still be a place to put very useful clinical information.
I suppose, as we mentioned earlier, the two complement each other, and actually a sort of gold standard approach would be to have as much information as possible.
Yes.
Mick, I think there are some potential challenges around the issue of discussing TEP forms and treatment plans and end-of-life issues with patients, particularly if you want to send the patient home with a form. If the form has to go with the patient, to travel with the patient to home, there has to be a discussion, doesn't there, either with the patient or as a minimum with their family, so that they're aware of the form and they're in agreement with it, and they're happy that it is a useful part of their planning ahead and their care plan. My experience in hospice medicine so far is that not everybody wants to engage with you in those discussions. People can find it enormously distressing and burdensome to think about planning ahead, prognosis, end-of-life care issues. And that's despite being given every opportunity to have those discussions. From an ethico-legal point of view, we're not obliged to have those discussions with patients if they don't want to go there with you. How do you think we should manage, what advice would you give to doctors about managing a situation where clinically it's your judgment that these treatments may not be appropriate? You want to send the patient home, but you can't really have that discussion with
clearly we can't unilaterally fill out a TEP form and send it with the patient, and even then have the patient perhaps just discover it in their own home setting and be potentially very shocked by what they're seeing. So
could be a nasty surprise.
Absolutely. I mean, so we just can't do that. If you like, we have to rely on more old-fashioned ways of communicating information, the discharge summary from the hospital to the GP, if necessary, a telephone conversation from hospital to the community setting to let them know what we think the plan should be, updating the end-of-life register such that the plan is accessible through that. So there are other ways of communicating information between health sectors, but clearly not having the TEP form in the patient's home environment.
I would agree with my palliative care hat on that the key thing is communication, isn't it? And when we have patients at the hospice who we're sending home, but really it's not been right to have that conversation, we would be contacting the GP, letting our community team of nurses know, who can liaise with community teams and GPs through the gold standard framework, updating the electronic end-of-life register, and just keeping those channels of communication and open. And it may be that at home opportunities to try and revisit those decisions could be had if it was felt appropriate. Thank you. It's been really, really helpful to talk through some of the issues and get a bit more information about TEP forms. There's lots of information out there, isn't there, for doctors and healthcare teams looking at advanced care planning, resuscitation decisions, care at the end of life, and national bodies such as the GMC, the BMA, Royal College of Nursing, the Resuscitation Council have produced very good and helpful documentation. I'm aware that the Devon TEP Development Group felt it would be useful to produce 5 key points about the TEP form, and I wondered if I could just close our chat by running through those. That would be very helpful. Yeah. The 5 key points that the TEP working group came up with were: 1, the treatment escalation plan form is a clinical decision-making tool, and common sense should be applied to who should have one. 2, only complete appropriate boxes. 3, the TEP form should be completed in collaboration with the patient and the family where possible, and should be reviewed over time. 4, the TEP is only good if everyone knows it exists, and update the electronic end-of-life register. And 5, the TEP form travels with the patient wherever they go. Thank you, Mick. It's very helpful. Is there any further information or a means of giving feedback about the TEP form that you could share with us?
Well, yes. Clearly there is a website which you may be accessing this DVD through, and there's plenty of more information, guidelines, protocols available on this website. We also have an email address if you wish to feedback and comment on anything to do with the TEP form and the TEP process. So please, all comments are gratefully accepted. And the details of the website and the email address will be captioned at the end of this DVD. So thank you.